Welcome to Enormous Nephrology. This is Volume 7 of the Hypertension Series, in which we will talk about low renin hypertension and resistant hypertension. All my talks will be housed at youtube.com/at Irfan Moinuddin-Kidney. That includes my board review series, my talks on hypertension, and other requested topics. Low renin hypertension comprises 20 to 30% of all hypertensive patients. So why are we talking about low renin hypertension? It comprises 20 to 30% of all hypertensive patients, but when you look at resistant hypertension, almost 70% of patients have the low renin hypertension phenotype. The most frequent form of low renin hypertension is essential hypertension. The remainder are secondary and genetic subtypes. Low renin hypertension, needless to say, is associated with increase in cardiovascular events. Any hypertensive patient whose PRA, plasma renin activity, is not inhibited is considered to have inappropriate amounts of renin, which may contribute to hypertension. Hypertensives with suppressed plasma renin activity levels can be classified as low renin hypertension. Plasma renin activity is measured by generating angiotensin I from angiotensinogen. Plasma renin activity values can vary according to reference population, age, assay, and salt intake. It should be measured in a seated or standing position 2 hours after waking up. The range for plasma renin activity is 0.6 to 4.3 nanograms per milliliter per hour, but this range doesn't really help us, as we will talk about in subsequent slides. Similarly, the range for aldosterone is 7 to 30 nanogram per deciliter, or as specified in other units. Again, the range does not really tell us anything. We cannot look at the range and interpret a particular plasma renin activity level or aldosterone level. However, aldosterone greater than 5 nanogram per deciliter can generally be considered to be high. Remember that in a hypertensive patient, aldosterone should be suppressed. A normal aldosterone is therefore actually relatively high. The traditional cutoff for low renin hypertension is plasma renin activity between 0.65 to 1 nanogram per milliliter per hour using an enzyme kinetic assay. As I said, aldosterone levels greater than 5 nanogram per deciliter is generally considered too high. Direct renin immunoassays directly measure the concentration of renin in plasma. However, low renin levels fall below the lowest calibration point. Direct renin immunoassays cannot approach the sensitivity of the enzyme kinetic assays, which remain the gold standard for the diagnosis of low renin hypertension. It's usually useful to look at the renin-aldo values together in a comparative way in what I call the renin-aldo phenotype. For example, the low renin high aldo phenotype is seen in primary hyperaldosteronism, in which you would expect a aldosterone to renin ratio greater than 20 and the actual aldosterone level greater than 15. Low renin hypertension implies a low renin value without regard to the aldosterone value, which is typically relatively high, even if the aldosterone level is normal. The focus of this talk is not on monogenic or rare forms of hypertension, so I will not delve into the details of monogenic or rare forms of hypertension, such as familial hyperaldosteronism, which would also manifest the low renin high aldo phenotype. In glucocorticoid-mediable hyperaldosteronism, ACTH activates cortisol and aldosterone production. Pseudohypoaldosteronism type 2 is Gordon syndrome, in which mutation in Wnt kinases leads to constitutive activation of the sodium chloride cotransporter. Aldo can be low, high, or normal, and this syndrome is sensitive to thiazide diuretics. When you see low renin and low aldo, you should generally think about generous salt intake, medications such as beta blockers, clonidine, alpha methyldopa, and NSAIDs, and any condition in which there is a reduction in nephron number. And this can be seen in diabetic nephropathy, chronic glomerulonephritis, solitary kidney, unilateral nephrectomy, aging, and reduced nephron number has actually been reported to be common in African Americans or Africans worldwide. Low renin, low aldo phenotype can also be seen in licorice, apparent mineralocorticoid excess, ectopic ACTH production, Liddle syndrome, congenital adrenal hyperplasia, and glucocorticoid resistance. Monogenic forms of low renin hypertension are extremely rare. Most patients with low renin hypertension are affected by essential hypertension. Hypertensives with suppressed plasma renin activity levels more likely have a sodium volume dependent hypertension. And I will keep emphasizing this particular point that this is a sodium volume dependent hypertension. Although low renin essential hypertension has an acquired component, up to 40% of the blood pressure variance is genetically determined as a polygenic trait. And this may be due to mild genetic polymorphisms and mutations. There may be, for example, a gain of function in renal sodium channels with defective negative feedback of aldosterone release. Again, aldosterone should be low, so a normal aldosterone level may indicate the presence of mineralocorticoid excess. I will emphasize this point again and again. Hypertensives with suppressed plasma renin activity levels more likely have a sodium volume dependent hypertension. Patients with low renin hypertension are thought to be more responsive to drugs having a natriuretic effect. Drugs having natriuretic effects include thiazide diuretics, loop diuretics, aldosterone receptor antagonists, and also calcium channel blockers, which induce renal vasodilation and inhibit tubular sodium reabsorption in addition to causing natriuresis. There is some data that some medications may be more effective in certain age groups or certain races. I will point out some of this data in a few slides, just because it does exist. For example, younger Caucasians less than 55 years tend to have higher renin levels than older and Black individuals of African descent, and it may be prudent to start off with RAS inhibition in this subgroup. There was one study which showed that calcium channel blockers are less likely to need a second agent as compared to thiazides or ACE inhibitors in South Africans. Hydrochlorothiazide may be more effective in Africans or in females. The recommendations of the British Hypertension Society, for example, are based on a study by Dickerson et al., which was published in Lancet in 1999. They studied ACE inhibitors, beta blockers, calcium channel blockers, or thiazide diuretics, or combinations of these drugs. And what they found was that in younger Caucasians, ACE inhibitors or beta blockers were most effective. In older Africans, calcium channel blockers or thiazide diuretics were most effective. And then for combination purposes, the most effective combinations were ACE inhibitors or beta blockers plus calcium channel blockers or diuretics. For triple therapy, the best combination was ACE inhibitor or beta blocker plus calcium channel blocker plus thiazide diuretics. If blood pressure is not at goal, even after combining three antihypertensive medications, addition of spironolactone is recommended. KDIGO, or Kidney Disease Improving Global Outcomes Organization, says that there is not sufficient data to recommend a specific sequence of antihypertensive medications when one is attempting to control hypertension. However, they do suggest that the same approach which was taken in the SPRINT hypertension trial may be the most optimal approach given the amount of data the quality of data that is currently available. In the SPRINT hypertension trial, they began with 2 or 3 antihypertensive drugs, including thiazide diuretics, ACE inhibitors or ARBs, and calcium channel blockers. And then they subsequently added therapy until the blood pressure was at goal, and then they continued that therapy. When a regimen of 3 antihypertensive medications fails to control blood pressure, typically a mineralocorticoid antagonist is recommended to be added. Granted, there are no contraindications such as declining GFR or markedly advanced chronic kidney disease. Eplerenone was more effective than losartan in Africans who have a high prevalence of low renin essential hypertension. In patients who have high renin levels, eplerenone and losartan were equally effective. In another study, eplerenone reduced blood pressure to a greater extent than losartan, and fewer eplerenone-treated patients than losartan-treated patients needed add-on therapy with hydrochlorothiazide for blood pressure control. Aldosterone to renin ratio and low renin activity favorably predicted the response to spironolactone in previously untreated patients. Spironolactone has a higher affinity for progesterone and androgen receptors, leading to side effects such as gynecomastia, sexual dysfunction, and mastodynia. Eplerenone does not interfere with the body's metabolic processes, making it a preferable option for patients with metabolic disorders. Spironolactone has additional adverse effects, including dehydration, hyponatremia, gastrointestinal problems such as nausea, vomiting, diarrhea, or anorexia, neurological abnormalities such as headache, drowsiness, asterixis, confusion, or coma, and skin rashes. So why do we use spironolactone and not eplerenone? Eplerenone is primarily metabolized by CYP3A4, leading to potential drug interactions with CYP3A4 inhibitors, which are more likely to occur with eplerenone. However, the potential drawback lies in its higher cost. Achieving the optimal dosage for hypertension treatment could translate into eplerenone costing 6 to 7 times more than spironolactone within 1 month. So should we check a plasma renin activity in all hypertensive patients? Um, Plasma renin activity-based approach has been reported to have a high monotherapy success rate, 60 to 80% by some authors. However, checking plasma renin activity indiscriminately is not likely to be beneficial. However, checking plasma renin activity in patients with resistant hypertension is likely to be beneficial. What is resistant hypertension? Resistant hypertension can be defined by a failure of 3 or more concomitant antihypertensive medications to lower blood pressure below 140/90 millimeters of mercury. This comprises about 30% of hypertensives. Approximately 60 to 70% of resistant patients are generally found to be low renin, and it has been suggested that plasma renin activity screening in resistant hypertensives is useful. So when exactly should you check plasma aldosterone and plasma renin activity? Um, You should check it in patients with hypertension with hypokalemia, whether it's spontaneous or on a low-dose diuretic. And if the blood pressure is greater than 140/90, despite appropriate doses of 3 antihypertensives. If you have hypertension with family history of hypertension or CVA at age less than 40 years, presence of an adrenal adenoma or a first-degree relative with primary aldosteronism, or if they simply have severe hypertension, which is blood pressure greater than 160/100. Other secondary causes of hypertension, which will not be discussed in this talk, include renovascular hypertension, chronic kidney disease or primary renal diseases, drug-induced hypertension, such as oral contraceptives, anabolic steroids, NSAIDs, chemotherapeutic agents, stimulants such as cocaine, calcineurin inhibitors such as tacrolimus or cyclosporin, and antidepressants, Cushing's syndrome, pheochromocytoma, and typically you should have the triad of pounding headaches, hyperhidrosis, and palpitations, obstructive sleep apnea, coarctation of the aorta, hypothyroidism, and primary hyperparathyroidism. Spironolactone is very effective in resistant hypertension, and we'll talk about spironolactone in some detail. For example, in this study published in the American Journal of Hypertension, the mean number of medications were reduced from 3.2 to 2.1 after introduction of spironolactone, and no patient discontinued spironolactone. Let's quickly review a study on the efficacy of spironolactone therapy in true resistant hypertension from Brazil, published in 2009 in Hypertension. The characteristics of the responders to non-responders was relatively symmetric, except for waist circumference and BMI, which was actually higher in the responders. So this was a study without control, and patients were on an average of 4 antihypertensive medications prior to addition of spironolactone. You can see that they did report PRA levels. And in general, this study included a good proportion of patients with low plasma renin activity, since the mean plasma renin activity was 0.7 to 1.0. Addition of spironolactone led to a marked reduction in blood pressure, whether it was in the office, whether it was on 24-hour blood pressure monitoring, whether it was during the daytime, or whether it was in the nighttime. The aspirin trial, published in 2011, also in hypertension, looked at the addition of spironolactone in patients with resistant arterial hypertension. And characteristics were similar between placebo and spironolactone groups. And this was a low renin study. As you can see, the plasma renin activity is 0.4 on average. Again, there was a marked reduction in blood pressure with the addition of spironolactone, whether it was ambulatory daytime, ambulatory nighttime, ambulatory 24-hour blood pressure monitoring, or in the office. The Pathway 2 trial, published in 2015 in Lancet, looked at spironolactone versus placebo, bisoprolol, and doxazosin to determine the optimal treatment for drug-resistant hypertension. In this double-blind, placebo-controlled crossover trial, they enrolled patients aged 18 to 79 years with seated clinic systolic blood pressure of 140 or greater, and home systolic blood pressure 130 or greater, despite treatment for at least 3 months with maximally tolerated doses of 3 drugs. And patients had to be on an ACE/ARB, calcium channel blocker, and a diuretic. Patients rotated in a pre-assigned randomized order through 12 weeks of once daily treatment with spironolactone, bisoprolol, doxazosin, and placebo, in addition to their baseline blood pressure drugs. 436 patients were screened, and 230 completed all treatment cycles, but 314 with any follow-up were included in the analysis. As you can see, the home systolic blood pressure on average was 147.6. The clinic systolic blood pressure on average was 157. The 24-hour urine sodium was 137.1. So the reference urine sodium would be around 50 to 150 milliequivalents. So the 24-hour urine sodium on average is not high at all. This is not a trial which is looking at hypertension due to salt consumption. The variable of salt consumption is not really a significant player in this trial. As you can see, the baseline blood pressure was quite high, and spironolactone was much more effective than placebo, and also much more effective than doxazosin and bisoprolol. Spironolactone reduced blood pressure by about 8 to 10 millimeters of mercury when compared to placebo, and by 4 to 6 millimeters of mercury when compared to doxazosin and bisoprolol. This graph shows blood pressure reduction stratified by renin values. And here the units are mu per liter. So I converted the units to nanogram per milliliter per hour. And I marked down the area that represents the low renin spectrum. So this is the low renin. And you can see that that's where spironolactone causes the most marked reduction in blood pressure. Again, testifying to the efficacy of spironolactone in low renin hypertension. But spironolactone, of course, is also effective in the renin values outside the low renin hypertension spectrum. So spironolactone should be used in resistant hypertension, even if the renin values are not low, but spironolactone is the most effective in low renin hypertension. So you can see that serious adverse events are not significantly higher with spironolactone. And if you look at any adverse event, they're about the same as doxazosin and bisoprolol, although slightly higher than placebo. So spironolactone is in pink, and as you can see, in the area of hyperkalemia, you see a little bit more pink, but not dramatically so. And see a little bit more pink in the hyponatremia zone that I've marked off carefully. Also a little bit more pink in acute kidney injury with a reduction in GFR. So let's look at pathway 2 mechanisms from 2018. Here they looked at endocrine and hemodynamic changes in resistant hypertension and blood pressure responses to spironolactone and amiloride. Again, the protocol was the same as the pathway 2 study that I previously described. The patients with the resistant hypertension were given placebo for 12 weeks, bisoprolol for 12 weeks, spironolactone for 12 weeks, doxazosin for 12 weeks, and then they used amiloride open label for 12 weeks. As you can see, the mean systolic blood pressure was 156 to 159. The 24-hour urine sodium, again, is about 148 to 153. Again, the 24-hour urine sodium is not high, so this is not a salt study. Hypertension is not significantly because of salt consumption. And renin, again, when you convert the units, you see that this is primarily a low renin hypertension study. Again, this is renin graphed against blood pressure, and the most marked reduction in blood pressure occurs in the low renin area, but also outside of the low renin area. And the most marked blood pressure reduction occurs when the aldosterone level is high. And then, of course, it makes sense that spironolactone would be most effective when the aldosterone-renin ratio would be very high, i.e. primary hyperaldosteronism. And here you can see that the renin values may change markedly, but aldosterone remains relatively horizontal over the whole spectrum of renin values. So when we say low renin essential hypertension, we're really only focusing on renin and not on the aldosterone. The aldosterone is assumed to be relatively high. Here we're looking at stroke index, vascular resistance index, cardiac index, and thoracic fluid index. So spironolactone does decrease stroke index and most markedly decreases the vascular resistance index. It does decrease cardiac index a little bit, as does bisoprolol. Spironolactone does have some parasympathetic effect. And then this thoracic fluid index is most markedly reduced by spironolactone, representing a marked improvement in fluid status. This shows the visual representation of the blood pressure reduction, most marked with spironolactone, but also with amiloride. But of course, amiloride is too toxic for routine use. So in summary, the KDIGO recommendations based on the SPRINT trial were to start off with a 2 or 3 drug antihypertensive regimen, including a thiazide, ACE or ARB, and a calcium channel blocker, and then successively adding therapies until you get to your goal of less than 120, and then maintain the person or patient on that regimen. And as I've shown you, for persons who have resistant hypertension, according to the definition of resistant hypertension, spironolactone is very useful and very effective. And However, of course, the caveat is that spironolactone may not be appropriate in patients whose GFR is declining or continues to decline, or if the patient has marked or advanced chronic kidney disease. Thank you very much for watching. Remember, all my talks will be housed at youtube.com/@irfan-moinuddin-kidney. Also check out my Handbook of Nephrology, second edition. This was published by Walter Schkluer. It shows my case-based storytelling approach to nephrology. See you next time.